My name is Sarah Figueroa, and my research question was, how does constraint-induced movement therapy improve upper extremity function for children with cerebral palsy? Currently, there are published research studies that support the short-term efficacy of CIMT in children with cerebral palsy. Results prove that upper limb function can be improved with proper implementation of this intervention. Although CIMT appears to be effective in children with CP, a majority of the literature failed to include an accurate sample size larger than 100 participants. Another gap found within the literature is the uncertainty of the amount of time that the unaffected limb must be restrained for the most effective results. Many studies also failed to incorporate the use of gold standard assessments to measure upper extremity function following CIMT treatment. Additional research is needed that evaluates the long-term benefits of CIMT in children with CP, includes a sufficient sample size, and uses gold standard assessments. The first study I found provided level 2 evidence and used subjects, including children aged 6 to 12 years old with a diagnosis of congenital unilateral spastic CP. The intervention investigated included subjects that wore an elastic bandage and restraint mitten on the less affected upper extremity as they practiced principles of shaping and repetitive task practice with the more affected upper extremity. Treatment took place in the child's home for 4 hours, 2 times a week, for 4 weeks. The comparison intervention included functional, unilateral, and bilateral upper extremity training, which included activity orientation, NDT, and motor learning and control. Treatment took place in the child's home for 4 hours, 2 times a week, for 4 weeks. The researchers concluded that CIMT generates more functional improvement in children with CP when compared to traditional rehabilitation. Some limitations of the study included they did not use gold standard assessments and they used a small subject size of 45 participants. The second study I investigated provided level 2 evidence, and the subjects included children aged 4 to 8 years old with a diagnosis of congenital hemiparetic CP. The intervention investigated included the subject's unaffected upper extremity restrained through the use of a sling and practice shaping and repetitive task performance using the affected upper extremity. Treatment took place in the clinic for 6 hours per day, 5 times a week for 4 weeks. The comparison intervention included gross and fine motor activities, of which related to the child's everyday activity and included no restraint of the upper extremity or shaping activities. Treatment took place in the clinic for 6 hours per day, 5 times a week for 4 weeks. The results concluded that improvement in upper extremity function in children with CP can be seen with the use of CIMT with shaping. Limitations of the study included a small sample size of only 30 participants and that the treatment took place at the same site location for all participants. The third study I found provided level 2 evidence and included subjects of children with a diagnosis of hemiplegic cerebral palsy. The intervention investigated included the subject's unaffected upper extremity in restraint with a sling and splint. Modified constraint-induced movement therapy training included completion of 13 tasks using the affected upper extremity, enforcing grasp, seize, and handling of objects of different sizes. Treatment took place for 60 minutes semi-weekly for 10 weeks. The comparison intervention simply included traditional rehabilitation therapy. The results concluded that improvements in hand dexterity and grip strength can be seen in children with CP who receive modified CIMT. Limitations included they did not use gold standard assessments, a small sample size, and the author did not specify who implemented the assessments and did not evaluate long-term effects. The final study I found provided level 3 evidence, and subjects included children with age 3 to 6 with a diagnosis of unilateral CP. The first intervention included subjects' non-involved arm being casted for continuous constraint during the first 18 days of treatment. Treatment included administration of motor learning and shaping principles, and the final 3-day focused on bimanual activities. Treatment took place for 6 hours per day and for 21 days for 4 weeks. The second group included subjects' non-involved arm casted for continuous constraint during the first 18 days of treatment. Treatment included administration of motor learning and shaping principles. Final 3 days focused on bimanual activities, and treatment took place for 3 hours per day for 21 days for 4 weeks. Statistical significance was seen in both groups, and the treatment group receiving SICK constraint-induced movement therapy for 6 hours per day displayed higher performance in the affected upper extremity than the group that received treatment for 3 hours per day.